to lecture number 12, Children with Special Needs. In this lecture on children with special needs, we will primarily talk about the prevalence of special needs or disabilities, some of the special needs categories or major disabilities, caring and coping issues, and counseling with parents of special needs children. I want to make a very clear disclaimer that what we have tried to do here through this lecture is to identify some of the very, very common disabilities and not go deep into the scientific or the psychological aspect of it, so that you get an idea and an understanding of special needs and how to address them. The 1998 to 2008 US statistics give 13.87% of the people have some kind of developmental disability. That's a huge number. 7.66% of the population have learning disabilities. 6.69% have attention deficit hyperactivity disorder, ADHD. And this is 1998 to 2008. And if you take 2008 to 2018 or 2017 as we record this lecture, that 6.69 may have doubled or even gone beyond that. Other developmental delays is 3.65%, and autism was 0.47%. Now, the same situations, if you look at the last 12 years, prevalence of DD has increased to 17.1%. That is about 1.8 million more children. Prevalence of autism, whopping 289.5% increase. Prevalence of ADHD, a whopping 33% increase. Males have twice the prevalence than females in these categories. Children from families with income below federal poverty level had a higher prevalence of developmental disabilities. So these are some statistics that we want to throw as we introduce the special needs issue. Now, what are some of the major special needs categories? Autism, emotional disability, deafness and blindness, hearing impairment, mental disability, multiple other disabilities, orthopedic impairment, other health impairments, learning disability, speech and language impairment, traumatic brain injury or otherwise known as TBI, visual impairments. All these are major categories of special needs. What are the common signs and symptoms of a child with special needs? You will see emotional disturbances, hyperactivity, aggression or self-injurious behaviors, withdrawal from society and from people, immature behaviors, learning difficulties, distorted thinkings, bizarre behavior, anorexia, not eating, bulimia, that is after eating and then putting the hand in the mouth and then throwing everything out, mood disorders. So these signs and symptoms manifest in different degrees in the cases of the people with these special needs. Now, the first category that we will deal with is developmental disability. It must be diagnosed at least after 5 years of age so that you really categorize it very clearly. It is not diagnosed at 2 or 3 because speech delay or walking delay, developmental milestone delay, may not exactly be a developmental disability. So the diagnosis, the formal diagnosis after 5 years of age. It can be attributed to physical impairment or a combination of mental and physical impairment. Most of the states do require, most of the countries do require that it must be manifested before the person attains 22. So the diagnosis or the assessment of DD, developmental disability, which used to be called mental retardation, no longer called as mental retardation in any part of the world, because that's a term that puts down the person with that disability. But it should be diagnosed before the person turns 22. And developmental disability is a problem that is likely or must continue indefinitely. Incurable condition. Once a brain cell is dead, it cannot be revived. So the fact that certain aspects of the brain is not working, and that is not expected to be revived back again from a physical and medical standpoint. What are the functional limitations of people with developmental disabilities? They are limited in self-care. They're limited in receptive and expressive language. In learning, they're limited. In their mobility, sometimes they're limited. In their ability to make decisions for themselves, independent living capacities, economic self-sufficiency, they're limited in these areas. So developmental disability varies. Some are mild, some are moderate, some are severe, some are profound. So in 4 different classes. So once a person is in a severe to profound class, all these functional limitations are more profound or prominent in their lives. The next most important category is ADHD, Attention Deficit Hyperactivity Disorder. It's a neurobiological disorder characterized by impulsivity, lack of attention, and many times with hyperactivity. Usually it develops by the age of 7, and usually it has a 2 to 4 year of developmental delay. The scientists, psychologists say that a person who is diagnosed with ADHD must at least show 6 specific characteristics present for at least 6 months in order for that person to be diagnosed. And we will just lay out some of those characteristics. And if 6 of them are present, then it is safe to categorize them as ADHD, or at least refer the person for a diagnosis if you see these being manifested. In the attention side of it, no attention to details, makes very careless mistakes, no sustained attention, does not listen to people, struggles to follow instructions of people, avoids or dislikes any attention to tasks, loses things very often, forgetful of daily activities. So these are all part of the domain of attention. And if 6 of these are present, the person could be ADHD. Now, it is attention domain only. Now, the 6 is a combination of attention as well as the action, the impulsivity part. And there are some characteristics that you see there. Has difficulty being seated. They have to be on the move all the time. Fidgets with the hands and the feet, always on the move. They just cannot sit still. Cannot engage in any activity quietly. They are always noisy and on the move. Cannot engage in a good move. They are always driven by, or acts as if they are driven by a motor. They talk excessively. blurts out answers before questions are completed. They don't even allow a question to be completed and they blurt out their answer. They have difficulty waiting or taking turns, interrupts and intrudes upon others. So if 6 characteristics from the attention side and the impulse or the action side is present, then the person can be safely categorized or be referred to someone for treatment. Now, what are the causes and what are the treatments? Unfortunately, the cause for ADHD has not been ascertained. Many linkages have been argued. Food, additives in food, genetic lineage, all those things have been argued, but nothing has been pinpointed as a cause for ADHD. Now, what are the treatments? One is behavior modification. The other is medication. And then the third is counseling and a special education program. So either a selected part of this treatment program or one combination of this or all of this could be utilized in order to make the treatment effective. Medication can be, Ritalin is used very commonly, Dexedrine is used very commonly, Maloril is used, Thorazine is used. So those are very commonly prescribed medications to calm the child down. Behavior modification is reinforcement of positive behavior, extinction of a stimuli that actually causes ADHD. Punishment or negative reinforcement is something that that has been used. In very commonly in some places may not want to use the word punishment, but more so withdrawing the reinforcement or withdrawing the reward, or sometimes having to stand in the corner or stand up in public and stand there for some time. All those are kind of like ways in which you can actually treat the issue and do behavior modification. So ADHD is a very alarmingly growing issue in our society these days. So we looked at DD, we looked at ADHD. Let's look at speech and language pathology. SLP, or speech and language pathology. It's either an expressive disorder or a receptive disorder. So an expressive disorder, expressive language disorder is like telegraphic style of speech, difficulty finding words. They kind of like rapidly speak, or like they have a monotone, or they are groping for words. So in order to express what is in their mind, they're not able to do so effectively. Now, receptive language disorder is the other part of speech and language pathology. Impaired understanding of language is part of the receptive language disorder. Early detection is very important in dealing with early intervention. Early detection and early intervention is very important in dealing with people with SLP, or speech and language pathology. Babbling is expected at 6 months of age. Single words are expected at least by 12 months of age. 5-word vocabulary at least by 20 months. 2-word phrases by age 2. Sentences by 3. If these are not happening, then parents should make an effort to have the child evaluated so that early intervention can prevent further deterioration of the situation. So what are the diagnostic criteria? Understanding and expressing single words, if that is not there. Comprehending and using grammar and syntax at certain age. Handling language as it increases in complexity and length at certain age. Reading and writing. All these are areas that we need to look at expected developmental milestone areas, so that the child is able to either meet them or not meet them. And if they are not able to meet them, then refer them to a speech and language pathologist. Learning disability is something that goes very much close to the speech and language pathology. A very common diagnosis, a commonly prevalent one, but often neglected, that we don't pay attention to learning disabilities. Failure to learn according to one's own ability is a learning disability. In the areas of reading, writing, spelling, calculating, all that, the learning disabled people are failing to meet the expectations that they set for themselves and other people have set for themselves. It's more prevalent in boys than in girls. Actually, it is a 4:1 ratio. If 4 boys have it, 1 girl has it, and that's statistical. Reading disability is a common one in learning disability, and that is dyslexia. Not able to spell properly, or reading it totally different. Instead of God, writing as dog, or instead of saying God, the word comes out as dog, and that is dyslexic. Trouble with the shapes and sizes, dyslexia. People with learning disability have problems. Poor handwriting is another problem. Behavioral and emotional problems. Visual and perceptual issues. They are ambidextrous. They do not have an established hand. I am right-handed, so I will hold a book with the right hand. I open it with the right hand. I write with my right hand. So I am able to use my right hand more strong than my left hand. But some of these people, they might use the left hand for some purposes that we only use the right hand for, and vice versa. Attention, concentration, listening, memory, following directions, they are not able to follow at the level that you expect them to. There is a language delay, difficulty in forming sentences properly. Reading, as I said previously, trouble sounding out words properly when they read. Misreads the letters. That's another problem with people with learning disability. So detecting this and having them follow an occupational therapist or a speech and language pathologist is a very important phase in early intervention in helping them deal with the learning disability so that the full potential of the person can be achieved before it is too late. The next one, a very prevalent, common problem that we are facing all over the world, autism. It's a complex developmental disability that typically appears during the first 3 years of life. It's a brain disorder that affects a person's ability to communicate, form relationships with others, and respond appropriately to the environment. Many autistic people look very normal to the outside world. And many autistic people are very high functioning. Some of them may be disabled, or lower functioning, but many of them are very high functioning. Some of the indicators, and you need to be very careful about this because this is one of the most fastest growing problems in the world. If a child does not babble or coo within 12 months, does not gesture, meaning pointing to people, by 12 months, does not use single words by 16 months, does not say 2-word phrases by 24 months, has some loss of any language or social skill at the growing ages, insists on routine. If the routine is affected, if they become upset, if they have difficulty in expressing some of their common needs, if they're using gestures at 3 years or 4 years instead of words, repeating words or phrases, or being echolalic, laughing or crying for reasons that you do not expect that expression to be there. If they prefer to be isolated and alone, if they are throwing tantrums more commonly, difficulty in mingling with people, not making eye contact with the people that they talk with, does not like to be cuddled or petted by other people, if they are unresponsive to normal teaching methodology, and if they are also in repetitive odd play in things that usually do not interest other people, if they have inappropriate attachment to objects, oversensitivity or undersensitivity to pain, do not have any fear of danger, they can walk into fire or water, physical overactivity in many cases, or sometimes extreme underactivity, uneven gross or fine motor skills. I mean, they can bump into people, or they do not have the finesse in the finer gross motor skills, not responding to verbal cues from people, acts as if deaf even when hearing tests are performed. All these are signs that we should look for to see if this is a problem that a child is currently having. So it could well be a spectrum, or it could be the actual autism. But if you look at these things happening in your child, or the child that is brought to you for counseling, or someone that you know in the community, we got to put an antenna up to know that there could be a potential problem. Now, need to understand the difference between autism and developmental disability. Autism is a developmental disability in many ways, but people with developmental disability and people with autism behave differently. Autistic people are very narcissistic, meaning they are very much about themselves. They love themselves and nobody else. But developmentally disabled people are very affectionate. They want the company of other people. Autistic people usually consider people as objects. Their language is very well developed. They have very highly elevated visual and perceptual skills. For people with developmental disability, usually these are just the opposite. They like to be cuddled, their language is limited, their visual and perceptual skills are limited as well. Now, you may be hearing a lot about autism spectrum disorders. Some disabilities that DSM, Diagnostics and Statistical Manual for Mental Disabilities, and International Classification of Diseases, ICD-10 and DSM-5, which are the current editions that are under circulation, used to have certain disabilities specifically listed, and now they have gone away, and they are now clustered under autism spectrum disorder. And it is a wide spectrum of symptoms, skills, and levels of disability, with ongoing social problems, repetitive behaviors, symptoms recognized in the first 2 years of life, symptoms that hurt the social, functional ability in school, work, and every other aspect of life. Alarmingly, 1 in every 68 children born in the world currently have ASD. 1 in every 68 child. Some of the common characteristics: they do not play pretend games. They do not point to objects to show interest. They do not look at objects when other persons point to them. They have trouble relating to others, avoids eye contact and want to be alone, have difficulty understanding other people's feelings, prefer not to be held or cuddled, appear to be unaware when other people talk to them, they're very much interested in people, but not in how they relate to them, but in using them for their own purposes, repeating or echoing words or phrases like echolalia. Most of these characteristics are part of the autism, but they're not as defined as autism are. So they're more in a gray area or in a spectrum area, and that's why they're called autism spectrum disorder. Very close to autism, but not specifically diagnosed as autism. Some of the autism spectrum disorders that used to have standalone diagnosis before, Asperger's, now no longer called Asperger's. They are anybody with Asperger's or Asperger's-like symptom is now considered to be an ASD. Pervasive developmental disorder or PDD, Prader-Willi, excessive eating and obesity, Rett's, almost exclusively in women, childhood disintegrative disorder, normal development first and then regression after 3 years. All these are part of autism spectrum disorders. I also want to bring cerebral palsy as another disorder that we have to be very careful about. It's damage to the brain, usually occurring before, during, or shortly after birth. Cerebral means the brain, and palsy means the posture, disorder to the posture or the movement. Usually it is due to prenatal causes, during the prenatal time when the mother may have abused some drugs or may have had some disease or may have been alcoholic or had suffered a fall or was not careful about the child growing. And during or after birth, accidents, viral infection, child abuse, Rh factors, ABO, blood group connection factors, genetic factors, all these could be causes of cerebral palsy. Actually, in statistics, they say chromosomal abnormalities account for 7% of cerebral palsy. Intrauterine infections and fetal functioning account for 32%. Labor and delivery complications, back in those days, the forceps delivery that causes brain damage, 17%. Neonatal sepsis or infections, premature delivery, 39%. Childhood meningitis, head injury, and toxins, 5%. What are the effects and the facts regarding CP? Causes or manifests with a lot of tonal problems, involuntary movements, spasms, problems with gait and mobility, a lot of seizure activity. Sight is not well developed, hearing is not well developed, speech is not well developed. Early intervention can help grow the potential, but not to any great level. About 3,000 babies in the US are born each year with cerebral palsy. There are three major types of CP. We'll just touch upon them. They're very detailed when it comes to their diagnosis and the characteristics. So I'll just touch upon those terminology. Spastic CP, which is stiff and difficult movements. Athetoid cerebral palsy, where involuntary and uncontrolled movements are occurring. Ataxic is disturbed sense of balance and depth perception. OT, PT, speech, assistive therapy, early intervention, all these are combinations that we can actually use to help the people with cerebral palsy. Another one that we bring up is Down syndrome, which is a trisomy 21 issue. Presence of an extra genetic material on the 21st pair of the chromosomes, resulting an anomaly in cell division during development. 95% of the people with Downs have this. Another is the translocation, where the extra chromosome 21 broke off. About 4% have that. Mosaicism is where some cells have trisomy 21. 1% has mosaicism. So Down syndrome is very genetic disorder that is prevalent in children. It's a developmental disability, but a specific developmental disability. Earlier on, they were not expected to live more than 60, 65 years, but now a lot of people with Down syndrome, with the advancement of medicine, have grown up and been to 70, 75, 80 years of age. Almond-shaped eyes, small ears, small head size, short, broad hands, with a single transverse palmar crease. All those things are kind of like typical physical characteristics. Mental disability is a very common one. It's a developmental disability. Down syndrome affects about 250,000 people in the United States alone. Can be very easily identified from their physical features itself. Epilepsy or seizure disorder is another special needs that we face in young people, children. It's a neurological disorder. It is characterized by seizures. It can be from anywhere from a few seconds to several minutes. There is partial seizure, partial epilepsy, or generalized epilepsy. It is detected or diagnosed with an echoencephalogram, or which is otherwise called as EEG. The partial, which is called the petit mal, or simple partial, partial has a simple partial and a complex partial phase. So the petit mal seizures, the simple partial is sensory motor, is jerking a foot, face, arm, involving the sense such as tingling or burning. Autonomic phase, face becomes flushed or pale. Heart may be beating fast. Abnormal cramps, loss of bowel control. Psychic phase stimulates emotions such as fear, feeling of end of the world, voices being heard, are all part of the simple partial petit mal seizure. The complex partial is where you start staring, you're confused, you're not alert, you have aimless movements, and even have loss of consciousness, and that is the petit mal seizures. Grand mal seizure, or the generalized seizure, has primarily two phases, the tonic and the clonic movements. The tonic phase is more of the loss of consciousness, rolling of eyes, stiffening of muscles, difficulty to breathe, face and lips sometimes turn blue, lasts for a few seconds. But the clonic phase is rhythmic jerking, fist starts clenching, lasts for a few seconds again, jerking slows, stops, and a deep sigh comes out. Then enters into a post-ictal stage for a few minutes. Not awake, not conscious, not responding. After this, sometimes they might just sleep or they arouse. And they may be tired, they may be confused and sore. So you have the grand mal seizure, you have the petit mal seizure, which is specifically identified by characteristics, but they are diagnosed with an EEG to know that this is actually a neurological disorder. Grand mal is usually treated with phenobarbital, dilantin, tegretol, Depakote, Klonopin. Petit mal is usually treated with Depakote, Klonopin, and Zerontin. Ketogenic diet is another way, high in fat and low in carbohydrates. That is another way in which many countries have been looking at the treatment. Some of the precautions: lay the person on the floor to avoid injury. Turn to one side to prevent choking or aspiration. There is a misconception that putting a spoon inside the mouth can prevent the tongue from rolling. The tongue cannot roll, and putting the spoon or inside the mouth can cause injury, because while the clenching of the mouth, they can hurt the parts of the mouth by having something metallic inside. Check the breath, chest for breath. Make sure that the person is breathing. Get another set of clothes immediately, because incontinence may occur. We talked about many disabilities in very, very minimal level or basic level. Even with the seizures, it may have been more scientific, even with just slicing it down to the basics. Caring for and coping with disability is not an easy thing. Expecting a child, having a dream child, a fantasy, handicapped child is born, shattered dream, grieving process, denial, anger, bargaining, depression, finally acceptance, not with a full mind. Physical manifestation: loss of appetite, restlessness, irritability, anger. All this is part of the life of the parent or the caregiver of a disabled child. Mothers become emotionally detached, worried about the day-to-day issues. Fathers become more concerned about the long-term problems, and sometimes they are in denial of the problem. Sometimes abuse and neglect occurs. Exceedingly taxing care of a child with a disability causes neglect sometimes, abuse sometimes. Feelings of being overwhelmed. I cannot do this. I have a life and this is too much for me. Increase of the potential for abuse and neglect due to that. Neglecting bringing them to school, medical appointments, because there is a lot of stigma attached to the disabilities. Attitude towards their own body changes. Social isolation starts occurring. Trouble achieving a balance between dependence and independence. Performance in academic and social areas become very much lowered. So much concern, and even it affects the siblings. They're worried. They have questions. Some people tell them that this is contagious and they might catch them too. They are torn between the obligation of caring and protecting their disabled sibling, while they're also concerned about their own peers not accepting them because they have a disabled sibling. But in the midst of all, they tend to become very altruistic, idealistic, humanitarian, tolerant, and relationship-oriented. Understand in counseling that these children are different from the norm. Their problem is just as much as the society's and family's perception of the limitation of the child. Counseling is just an only part of the treatment of the child. Counseling is more for the coping, the caregiver, than for the child who's disabled. It is treatment as required and then helping the person deal with the coping mechanisms in caring for the child is where counseling plays a very important part. Work to change the child's image and expectations is part of counseling. Work allowing him or her to grow to their full potential. Their self-esteem is very low. You can help boost that up. Individual and group counseling can help them feel belonged in a group. Come to terms with their own disability. Realize that there is an element of frustration that can set in at any time because of the shattered dream in their lives. And so working with people with developmental disabilities may not be rewarding all the time. Recognize the expertise and the experience of the parents while counseling them, because they might put that out on the table that can get the counselor worked up a little bit. Provide accurate diagnosis in very clear terms where scientific tests or medical tests are required. Have them go for medical tests. Give enough time for counseling and questions. Do not rush them into it. The goals of counseling with people with special needs is helping parents and family members with the education that they need, connecting them to available resources in the community, helping them set realistic expectations that they do not expect this to be magically cured, help them to realize their child's unique situation, parents and family support groups to be set up, psychoeducation to make them understand the situation that they are in. It is not a fully curable situation because the disability itself is many times non-curable. Making them understand the disability, getting early intervention and help as needed, and then helping them cope with the situation, maximizing the potential, are the goals of a counselor in dealing with people with special needs and dealing with the caregivers of the people with special needs.